Thank you for joining us for CDC's Public Health Grand Rounds. Today's session is a new venture for us as we transition from live in-person sessions to virtual ones. To minimize any technical issues, we have recorded our speakers in advance, but they are all here with us today and will be participating in our Q&A at the end of the presentations. Be sure to email your questions to grandrounds@cdc.gov. With us today is the Surgeon General of the United States, Vice Admiral Jerome Adams. We are honored to have him introduce this special Grand Rounds. Dr. Adams?
Thank you for inviting me to introduce this important session of CDC's Public Health Grand Rounds. One of the most significant public health successes in modern U.S. history has been the reduction in smoking that has occurred during the last half century. Today, the prevalence of cigarette smoking among American adults is at 14%, an all-time low. Although this overall achievement is a source of pride, there's still much more work to be done because 34 million Americans still smoke. Cigarette smoking among adults remains the leading cause of preventable disease, disability, and death in our country. We know that about 70% of adult cigarette smokers want to quit, and many of them have tried. And we understand that quitting can be difficult. The good news is we also know what works. We have evidence-based tools ready for use today. New FDA-approved medications, especially when combined with counseling, have been very effective. Support services, including text messaging and web-based applications, are helping too. It's important people know it's never too late to quit, regardless of your age or how long you've been smoking. Quitting reduces the risk of premature death and can add as much as a decade to life expectancy. Many of you have probably heard me speak about my own family history with tobacco. Several members of my family smoked, including my grandfather. Having asthma that was hard to manage when I was younger made this an added challenge. But beyond that, I also saw firsthand how smoking negatively impacted my grandfather's health. Its complications ultimately led to his passing. I share those reflections because they're tragically all too common. But the good news is we know that does not have to be our collective future. Everyone has a role to play to help people quit smoking. Healthcare professionals can start by asking every patient if they smoke, and if so, offer them services that can help them quit. Payers can cover medications and counseling with no barriers, including pre-authorizations and cost sharing. Policymakers can adopt best practices such as smoke-free spaces and mass media campaigns that educate everyone about the risk of smoking. And finally, everyone can share information about the free resources available to help smokers quit. For instance, by calling 1-800-QUIT-NOW. Over the last 3 years, more than 150 experts have contributed to this cessation report. Many are online with us today, and I want to personally thank them for their dedication to this effort. It is my hope that this historic report will help others who wish to quit smoking and put them on the path to successfully do so. And all of you have been a part of that. Thank you.
Thank you, Vice Admiral Adams. We're honored to have you join us today. I'm Dr. John Iskander with CDC's Office of Science. Thank you for joining us for our first virtual public health Grand Rounds. We offer free continuing education available for physicians, nurses, pharmacists, veterinarians, health educators, and others. The course code is PHGR10. Please see the Public Health Grand Rounds website or the CDC Continuing Education website for more details. Here is our continuing education disclosure for this session. Please note that brand names, images, and trademarks are used for identification purposes only. Again, we invite you to send questions to grandrounds@cdc.gov. We may be able to include your question during our Q&A part of the session. Want to know more? We have a featured podcast on our website called Beyond the Data, which is posted after the session. We've also partnered with CDC's Public Health Library to feature scientific articles about this session. Full listing is available at cdc.gov/scienceclips. Here's a preview of upcoming Grand Rounds topics. We hope you will join us live or on the web at your convenience. Today's speakers are Dr. Brian King Deputy Director for Research Translation at CDC's Office on Smoking and Health, Dr. Rachel Grana, Program Director for Tobacco Control Research Branch at the National Cancer Institute, National Institutes of Health, Dr. Jillian Schauer, Senior Consultant at CDC, and Dr. Amanda Graham, Chief of Innovations at the Truth Initiative. It's now my pleasure to introduce Dr. Rebecca Bunnell, CDC's Director of the Office of Science.
Hello, I'm Dr. Rebecca Bunnell, the Director of CDC's Office of Science, and I want to wish you a warm welcome to CDC's first ever virtual public health grand rounds. Before I say a few words, I want to acknowledge the frontline public health workers and clinicians who are joining us today. Thank you for all your hard work, service, and dedication. The COVID-19 pandemic has brought to light many challenges in public health and beyond. It has reminded us of the importance of taking proper precautions to keep ourselves, our loved ones, and our communities healthy and well. As many of us have been spending more time indoors and in close contact with family members during this time, we are reminded of the dangers posed by tobacco smoke and tobacco products to those we love. There's never been a better time to quit smoking or to stop using other tobacco products. Each year, an estimated 1.3 million people quit smoking. Since 1965, over 40% of all adults who have ever smoked have overcome the challenges of breaking their nicotine addiction and have successfully quit smoking. As you know, quitting smoking and tobacco product use yields near immediate health benefits to persons of all ages. Simply stated, it saves lives. CDC has worked closely with the Office of the Surgeon General to produce influential Surgeon General's reports on the impacts of smoking and vaping on health. These reports have become gold standards in public health and science communication and are widely cited in the scientific literature. You may have seen them mentioned in both traditional and social media as well. The most recent collaboration between CDC and the Office of the Surgeon General was published in January of this year and focuses on progress that has been made in tobacco cessation, as well as the goals for what we must still accomplish. Today, you will hear from speakers from CDC, the National Institutes of Health, and the Truth Campaign, a nonprofit dedicated to helping our youth live tobacco-free lives. These speakers will address the progress that has been made in helping tobacco users quit, what barriers remain, and what effective interventions exist to aid tobacco cessation at individual, clinical, and societal levels. Ending the tobacco epidemic is absolutely essential for our nation's health. It will take both prevention of youth initiation and cessation to get us there. Please join me in extending a warm virtual welcome to our speakers. Thank you.
Thank you, Dr. Bunnell. We will begin our session with Dr. Brian King.
Hi, and thank you for joining us today. The most recent Surgeon General's report on smoking and health, which was released in January 2020, focuses on smoking cessation, but it isn't actually the first such report to be released. This new report is part of a long-standing legacy of U.S. Surgeon General's reports on tobacco, which actually began more than a half-century ago to document the risks of smoking as well as the evidence-based interventions that we know work to prevent and reduce these risks. Now, it's been said that in order to know where you're going, you have to know where you've been, and that's particularly true in the context of tobacco prevention and control. To that end, we've organized today's presentation according to the past, the present, and the future of tobacco cessation in the United States. In the following presentations, we'll provide a historical perspective. We'll discuss the current tobacco control landscape in the context of the recent Surgeon General's reports, and then we'll provide a glimpse into the future, including opportunities for expanding tobacco cessation activities to include novel products, such as e-cigarettes, particularly in the context of youth. Now, the first Surgeon General's report on smoking was released in 1964 by Dr. Luther Terry. Since that time, we've amassed a considerable body of scientific evidence that documents the risks of smoking. That science shows us that smoking harms nearly every organ of the human body. And today, many people may think that the war on smoking is won, but that's actually not the case. We still have more work that we need to do. There's an estimated 34 million U.S. adults who still smoke cigarettes, and smoking causes 480,000 deaths per year in the U.S. Moreover, for every one death from smoking, another 30 Americans are living with a smoking-related disease. And not all the risks of smoking are necessarily well known. For example, we of course recognize the enormous impact that COVID-19 pandemic is currently having on all of our lives. While scientific evidence is still accumulating, we know that smoking suppresses the immune system, and that people who are immunocompromised are at greater risk for severe illness from COVID-19. But we also know that there aren't just human costs associated with smoking. Cigarette smoking costs the U.S. economy more than $300 billion per year in direct healthcare costs and also lost productivity. Now, the decline in cigarette smoking in the United States is among the greatest public health achievements of the past century. Indeed, smoking has been declining steadily among adults since the mid-1960s and among youth since the late 1990s. Today, smoking prevalence is about 9% among U.S. high school students and about 4% among U.S. adults. That's a commendable feat, considering the smoking rates were more than 40% among adults in the 1960s and more than 35% among high school students in only the mid-1990s. But as I noted, we've still got more work to do. And despite the progress that we have made in reducing smoking overall that I just noted, the bad news is that disparities persist. Cigarette smoking rates are particularly high among American Indians, individuals with lower education and income, those who are uninsured or underinsured, those with disabilities, and those in the LGBTQ plus communities. And some of the most marked disparities exist among those with behavioral health conditions, which is described as serious psychological distress by the survey used to obtain those estimates. We know from the available data that nearly 1/3 of individuals with mental illness currently smoke cigarettes, and about 40% of all cigarettes consumed in this country are among those with mental illness. So why aren't we smoking, the smoking rates even lower? And why do these marked disparities persist? Well, in 2000, Surgeon General David Satcher summed up the issue by stating that our lack of greater progress in tobacco control is more the result of failure to implement proven strategies than it is the lack of knowledge about what to do. So the bottom line here, folks, is that we know what works to effectively prevent and reduce smoking in this country, and the U.S. Surgeon General's reports on tobacco has served an instrumental role in providing this critical scientific evidence. And this recent report on cessation is actually the 34th Surgeon General's report on tobacco that's been released since 1964, and the first such report was specifically focused on cessation since 1990, so 30 years ago. Now, the primary purpose of this 2020 report is to update and expand that 1990 report. Since 1990, the scientific literature has expanded greatly on the determinants and the processes of smoking cessation, which has helped to inform the development of interventions that help smokers quit. In addition, the reach of smoking cessation interventions has increased substantially since 1990, with the emergence of innovative population-level interventions and policies that motivate smokers to quit and raise awareness of the health disparities of smoking cessation. Now, the Surgeon General's report that we're talking to you about today was coordinated by CDC using a long-standing, peer-reviewed, balanced, and comprehensive process designed to safeguard the scientific rigor and practical relevance of these reports from influences that could adversely affect impartiality. And so, in brief, under the leadership of a senior scientific editorial team, 32 experts wrote the initial draft of the chapters, and these contributions are summarized in the report chapters, which you'll hear about today. And these were evaluated by 46 peer reviewers. And after this initial stage of peer reviewers, more than 20 senior scientists and other experts examined the scientific integrity of the entire report as part of a second stage of peer review. And so throughout that review process, the content was revised to include studies and information that were not available when the chapters were first drafted, again, to make sure that they're as relevant and timely as possible. And so as you can see, this process doesn't happen overnight. And total compilation of this report took 3 years. And it also doesn't happen alone. It truly takes a village. More than 115 individuals contributed to the realization of this report from its conception to its release. And the full report, which is organized in 8 chapters, is more than 700 pages long. And its key findings are summarized in 10 major conclusions and 101 chapter-specific conclusions. Now, before I close, I will like to note that this report follows a long-standing framework for interpreting scientific evidence, which was first developed in the 2004 Surgeon General's report. Specifically, the report provides a 4-level hierarchy of categories for interpreting the strength of the evidence on a given topic. That's evidence is sufficient to infer a causal relationship, evidence is suggestive but not sufficient to infer a causal relationship, evidence is inadequate to infer the presence or absence of a relationship, and finally, evidence is suggestive of no causal relationship. However, consistent with past Surgeon General's reports on tobacco, conclusions in this report are not limited to just causal determinations and frequently include recommendations for research, policies, and other actions. This is done to ensure that the scientific evidence is summarized and presented in a way that allows it to best be translated into public health practice. So now that you've got the 411 on Surgeon General's reports on tobacco, I'd like to turn things over to Dr. Rachel Grana, my colleague from the National Cancer Institute, who will review the findings from chapters 1 through 4 of the recent report on cessation. Thank you.
Thank you, Dr. King. I'm very honored to have been on the team to develop this report and to be here with everyone today. As we begin to delve into the findings and the recommendations of this voluminous report, I wanted to begin with a broad overview of its content. The glimpse of this table of contents shown here demonstrates the breadth of the science summarized in the report, from epidemiology to clinical and health outcomes research to basic biology and economic and policy analysis. I will present some of the major findings from the first 4 chapters, and Dr. Schauer will focus on chapters 5 to 8. Keeping with our session's theme of past, present, and future, the report's first chapter provides the historical and scientific background since the 1990 report, much has changed, and an overview of the current landscape of smoking cessation. It presents in the form of major conclusions, a roadmap for actions that can be taken to increase smoking cessation now and into the future. There were 10 major conclusions in this report, drawn from the about 100 chapter conclusions that Dr. King reviewed. This report concluded that smoking cessation is beneficial at any age, can reduce the risk of premature death, reduces the risk of cardiovascular diseases, chronic obstructive pulmonary disease, several cancers, and adverse reproductive health outcomes. It also concluded that cessation can be increased by a variety of tobacco control policy and communication approaches, of which we're very familiar, including like cigarette taxes and price increases, smoke-free policies, mass media campaigns, and statewide tobacco control programs. The report also found that we have evidence-based interventions, both behavioral and pharmaceutical, that increase one's chances of successfully quitting, especially when used in combination, and that these evidence-based approaches are also cost-effective. It covers insurance, the topic of insurance coverage. Insurance coverage for smoking cessation can increase rates of quitting, but needs to cover all forms of treatment, be widely promoted, and free of barriers such as out-of-pocket costs. Importantly, the report concluded that smoking cessation reduces the substantial financial burden from smoking, both to the individual and on the societal level. However, the report conclusions also highlight some remaining challenges. While most smokers attempt to quit each year, only a minority use those evidence-based cessation strategies like behavioral counseling and multiple FDA-approved medications. And there are significant disparities still in both smoking and the population markers of smoking cessation, such as quit attempts. In populations who have a higher prevalence of smoking, they're less likely to engage in these smoking cessation behaviors. So we have more work to do. Of note, the report also touched on the science pertaining to e-cigarettes in the context of smoking cessation. This report really emphasizes and acknowledges the heterogeneity in these products. The whole product class represents several hundred types of products, and the use behaviors, which are also heterogeneous, and complicates making generalizations about their efficacy for smoking cessation. So the scientific conclusion states that at this time, there is inadequate evidence to conclude that e-cigarettes in general increase smoking cessation. Now I'll move to the second chapter of this report, which really documents the key distributions, trends, and determinants of smoking and smoking cessation behaviors. It focuses on both current status and trends over time, and primarily focuses on adults, but there are data and conclusions about cessation among youth and young adults. And when I refer to adults, young adults, and youth, the terms correspond to the age ranges listed here, such as 18 and above for adults and 18 to 24 for young adults. The evidence presented in Chapter 2 really illustrates the progress we've made and the work that we have to do. In the U.S., more than 3 out of every 5 adults who were ever cigarette smokers have quit smoking. And smoking cessation behaviors like quit attempts have also increased. The use of evidence-based cessation counseling and the FDA-approved cessation medications have increased among adult cigarette smokers. Yet, more than 2/3 of adult cigarette smokers who tried to quit in the past year did not use those evidence-based treatments. So really, that is a major opportunity. Receiving advice from health professionals to quit smoking has also increased dramatically in the past 2 decades, yet 4 out of every 9 adult cigarette smokers who saw a health professional in the past year did not receive this advice to quit. Cigarette smoking also remains highest among certain populations, such as people with mental health conditions, substance use disorders, lesbian, gay, bisexual, and transgender adults, and American Indian and Alaska Native populations. And there are marked disparities not just in smoking, but in the cessation behaviors among some population subgroups, such as those defined by factors like educational attainment, poverty status, and race ethnicity. And these disparities may be affected by these systemic issues, such as lower levels of receiving advice to quit from a health professional, or less use of evidence-based treatments. The graph I'm showing you here shows the quit ratio, or the percentage of adult ever smokers who have quit smoking over time. This graph starts at the year that the first SGR on smoking and health was published in 1964, and the last data point is in 2017. You can see here that across age ranges, these time trends in quit ratios vary. While it's encouraging that more than half of ever smokers have quit, younger smokers have lower quit ratios compared to older smokers. For instance, the most recent data for the young adults shows that their quit ratio is only around 30%, just half of the average here, shown here. So, however, over the past several years, young adults and adults up to age 44 have shown slight increases in their quit ratios, but this still represents an opportunity to do better. Chapter 3 of the report reviewed research into the basic biology of smoking and smoking cessation. These lines of investigation provide very important insights that complement the epidemiology and intervention research presented in the report. But I do want to emphasize that this chapter discusses new biological insights, and thus by very nature is more explorative and covers novel topics. As such, not surprisingly, all of the conclusions in this chapter met the suggestive but not sufficient threshold and category for causal influence. This type of work is important to inform ongoing dialogue about cessation, but these are emerging topics that warrant more nuanced research and understanding before stronger recommendations can be made. The chapter reviewed the evidence in 4 different domains of biological insights: cellular and molecular biology of nicotine addiction, immunotherapies, including vaccines as treatments for nicotine addiction, the neurobiology of smoking cessation, and the genomic factors in smoking, nicotine addiction, and smoking cessation. The conclusions in this chapter are presented on this slide, as I said, categorized as suggestive but not sufficient. And while I will not go through in detail every one of these specific conclusions, I will summarize some of the main insights from this research. The cellular and molecular mechanisms of nicotine addiction, including the rewarding properties of nicotine, withdrawal symptoms, and relapse, are now pretty well known. We have good animal models and a wide array of medications that target various neurotransmitter systems, and new ones are in development. Brain imaging technologies such as MRI and fMRI have really helped advance our understanding of how the brain changes during addiction, withdrawal, and during the pharmacotherapy treatment with the FDA-approved medication, and how smoking cues and anti-smoking messages affect brain function. Vaccines generate adequate levels of nicotine-specific antibodies that can block the addictive effects of nicotine to aid smoking cessation. However, despite these promising results from animal studies, more research is really needed in humans to develop nicotine vaccines without intolerable side effects. And the evidence from the genetic research reviewed in this chapter found that the effectiveness of nicotine replacement therapy may vary across specific genotype groups. This suggests that someday we may be able to tailor cessation treatments to specific genotypes, which would maybe perhaps make treatment less of a trial and error process. However, this chapter really underscores that more research is needed regarding nicotine dependence and the role that genes play in smoking, nicotine addiction, and in cessation. The last chapter I'll review in my time is Chapter 4 on the health benefits of smoking cessation. Smoking cessation has numerous health benefits documented here that cut across both organ systems and age groups. And this chapter really extensively reviewed that evidence with particular attention to how these risks change after smoking cessation for the major types of chronic diseases and reproductive health outcomes. So based on strong scientific evidence reviewed in this chapter, it shows that smoking cessation is linked to reductions in the risk of 12 types of cancers, both as initial diagnosis and also following cancer diagnosis, for instance, like with recurrence. It reduces morbidity and mortality of disease from cardiovascular disease and stroke, and cessation can even improve outcomes for adults who have already been diagnosed with coronary heart disease. Reduces the risk of respiratory disease like chronic obstructive pulmonary disease. And finally, smoking cessation can reduce a variety of adverse reproductive health outcomes, including low birth weight and preterm birth. Beyond these disease-specific benefits, smoking cessation at any age can yield broader health benefits, including increasing life expectancy by up to a decade. And all of these benefits not only accrue to the person who lives 10 years longer after quitting smoking, but to all of us through more time with our family members who smoke, reduced healthcare costs, and decreased secondhand smoke exposure. So in summary, the evidence reviewed in this chapter on health benefits demonstrates that it's never too late to quit. Thank you for your attention today, and our next speaker is Dr. Jillian Schauer from CDC.
Thank you, Dr. Grana. Like Dr. Grana, I'm also honored to have been a senior editor on this important report and happy to be with you today. I'll be talking about the second half of the report, which includes scientific updates to the health economics of smoking cessation, a review of the evidence surrounding effective interventions that can increase the chances of quitting from the individual to the population level, and future considerations for smoking cessation and for tobacco control in general. Now, we've just heard about multiple health benefits that follow smoking cessation. Decreases in the morbidity and mortality from smoking-related illness are also one of the chief drivers of the economic benefits from cessation. And Chapter 5 discusses that in more depth. Sufficient level conclusions from this chapter span from the individual to the system to society, and they include that smoking cessation improves well-being, quality of life, and overall health status, that smoking cessation reduces mortality and increases the lifespan, that smoking has a high cost to smokers, healthcare systems, and society, and that smoking cessation interventions are cost effective. Now, in terms of helping smokers to quit, evidence supports multiple types of clinical and public health interventions. In 2008, the U.S. Public Health Service released a clinical practice guideline on treating tobacco use and dependence. And this year's Surgeon General's report builds on that guidance and adds more than a decade of additional research. Chapter 6 not only reviews the evidence around interventions to help people quit, but also the evidence around modes or methods for delivering those interventions, settings in which those interventions can be delivered, and teachable moments in which cessation interventions can have a particular impact. Similar to the 2008 Public Health Service guideline, this report found sufficient evidence that behavioral counseling and cessation medications are independently effective in increasing smoking cessation, and that they're even more effective when they're used together. This particular combination of counseling and medicines can increase smoking cessation compared to self-help materials or no treatment. In terms of behavioral interventions themselves, the report found sufficient evidence that proactive quitline interventions used alone or in combination with medicine can increase cessation. And proactive in this case means that the quitline is reaching out to the individual. The intervention is not dependent on the individual to reach out to the quitline. The report, as I said, also looked at how we deliver behavioral interventions, and there the evidence was sufficient to infer that short text messages about quitting independently increase smoking cessation, and that those are most effective when they're interactive or tailored to individual responses. The report also found sufficient evidence that web or internet-based interventions increase smoking cessation, especially when they deliver proven behavior change techniques, like, for example, if they include motivational interviewing or cognitive behavioral therapy. The evidence was inadequate for smartphone applications at this time. So let's talk a little bit about cessation medications or medicines. The evidence is sufficient that combining short-acting nicotine replacement medicines like the nicotine gum or lozenge with a long-acting form like the nicotine patch increases smoking cessation compared to using just one form of nicotine replacement therapy. And this conclusion is an important addition to previous federal reports on tobacco cessation treatment. With regard to e-cigarettes or electronic cigarettes, the report acknowledges that they comprise a heterogeneous class of products, including disposable devices, rechargeable devices, tanks and mods, and the most recent nicotine salt mod pods. At this time, the evidence is inadequate to infer that e-cigarettes in general increase smoking cessation. The evidence is suggestive but not sufficient to infer that using e-cigarettes that contain nicotine is associated with an increase in smoking cessation compared to using e-cigarettes that do not contain nicotine. And finally, the evidence is suggestive but not sufficient to infer that more frequent use of e-cigarettes is associated with increased smoking cessation compared to less frequent use of e-cigarettes. And I should mention that the e-cigarette conclusions in this report are similar to the conclusions from the 2018 National Academies of Sciences, Engineering, and Medicine report, and that this report also acknowledges that these conclusions need to be considered in the broader context of youth use of e-cigarettes. Now, moving beyond interventions that target individual smokers, Chapter 7 discusses strategies that have been shown to be effective in promoting cessation within clinical and healthcare systems, as well as in the broader society. Within clinical and healthcare systems, first, the use of evidence-based clinical guidelines, such as the U.S. Public Health Service guideline that I referred to earlier, increases utilization of clinical interventions for smoking cessation. Second, tobacco cessation insurance coverage that is comprehensive, barrier-free, evidence-based, and adequately promoted increases the availability and utilization of smoking cessation treatment. And in this case, barrier-free means that there are no pre-certification requirements, no copays or deductibles, and comprehensive means that a variety of smoking cessation treatments would be covered. Third, linking smoking cessation-related quality of care measures with payments to clinicians, clinics, or health systems can increase the delivery of clinical treatment for smoking cessation. And finally, tobacco quit lines such as 1-800-QUIT-NOW are an effective population-based approach to encourage quit attempts and increase smoking cessation. Now, a number of broad tobacco control policy efforts have been shown to increase smoking cessation, and those include increasing the price of cigarettes, smoke-free policies, mass media campaigns like CDC's Tips from Former Smokers, comprehensive state-based tobacco control programs, and according to CDC guidance, comprehensive includes providing adequate levels of funding for such programs, and then large health warnings on cigarette packaging in the form of pictures. Now, most of these interventions also have additional benefits to tobacco control, including reduction in smoking prevalence and cigarette consumption. There are additional policy efforts that may increase the smoking cessation rates, and those include plain packaging of cigarettes and other tobacco products, decreasing the availability of tobacco products and the exposure to tobacco marketing and advertising at the point of sale, restricting the sale of menthol and other flavored types of tobacco products. Now, the report's final chapter, Chapter 8, brings together information about the history, the current status, and the future prospects for helping even more U.S. smokers to quit as one important step towards a tobacco-free society. As shown on this figure, while per-person cigarette consumption has decreased by around 75% since the release of the first Surgeon General's report on smoking and health in 1964, per capita cigarette consumption remains equal to about 1 pack of cigarettes per adult per week. Also notable from this figure is that major policy and communications advances in tobacco control, things like increasing the price of cigarettes and banning broadcast advertising, have frequently been followed by decreases in cigarette consumption. In 2014, on the 50th anniversary of the first U.S. Surgeon General's report on smoking and health, another Surgeon General's report was released, which, among other things, tried to anticipate ways that we might continue to work towards ending the epidemic of tobacco-related disease. Approaches discussed in that report included, among other things, reducing the nicotine content and the overall toxicity of cigarettes and tobacco products, and reducing or more strictly regulating the overall supply, availability, and sale of tobacco products. As we've mentioned previously, the 2020 Surgeon General's report, as well as all previous reports and additional related materials, are available on the websites of the CDC Office on Smoking and Health and the Office of the Surgeon General. Thank you so much for your time and for your interest in this important report. While this report focused on adults, as we look to the future and specifically as we look to ways to help youth end their use of tobacco products, I'm honored to introduce our final speaker for today, Dr. Amanda Graham, who's the Chief of Innovations at the Truth Initiative. Thank you.
Thank you, Dr. Schauer. For those of you who are not familiar with Truth Initiative, we are the largest nonprofit public health foundation in the U.S. dedicated to making tobacco use a thing of the past, especially among young people. My talk today will review the current status of tobacco product use among youth, the evidence behind various cessation strategies, and the impact of a youth vaping cessation program that we developed at Truth Initiative. These are data from the National Youth Tobacco Survey over the past decade, showing the percentage of high school students reporting past 30-day tobacco product use. The very good news is that cigarette smoking is at an all-time low. And the use of most other types of tobacco products has also been either declining or stable. In contrast, there's been a steady increase in youth e-cigarette use, most notably over the past few years. What you can see on this chart is that in 2019, 27.5% of high school students reported past 30-day e-cigarette use. We know that nicotine exposure among young people can have lifelong negative impacts, which make these data about e-cigarette use very troubling. Many of the tobacco cessation interventions that have been tested among young people overlap with the adult approaches that Dr. Schauer just reviewed. These include various types of behavioral counseling delivered through channels specifically designed to reach and engage young people, like school-based interventions and technology-based programs. Nicotine replacement therapy and several prescription cessation medications have also been tested among young people, though neither form of treatment is currently approved for use among adolescents. This slide summarizes the evidence behind these different cessation strategies from the most recent Cochrane systematic review that was published in 2017. What you can see is that group counseling was the only behavioral intervention that showed a statistically significant effect in promoting cessation, and none of the medications that were tested were effective among adolescents. A systematic review by Volanti and colleagues that was published just last month found that text message interventions are effective for promoting cessation among young adults. Two things worth noting on this slide: there have been many more studies of behavioral interventions than medications, and the vast majority of trials have focused on cigarette cessation. To date, there are no published trials of e-cigarette cessation interventions. So this last slide may seem like dismal news for young people who are interested in quitting tobacco, but there are a number of promising innovations that include web and app-based programs, new approaches being rolled out by state quit lines, and school curricula for middle and high school students. For many years, the primary focus has been on preventing youth tobacco use, and so it's exciting to see the increased focus on cessation from academic groups, government agencies, and the private sector. There are also resources and interventions targeted to parents and guardians of young people. Many of these interventions focus on basic education about e-cigarettes, how to recognize the devices, how to talk to a child about vaping, and most importantly, how to help a child quit vaping. At Truth Initiative, we developed a text message program specifically to help young people quit vaping called This Is Quitting. The program is theory-based, it's grounded in the best practices from the smoking cessation literature. It's fully automated, there's nothing to download, and it's available 24/7. We've tailored the program by age, by device type, and by quit date. The program is highly interactive. There are a number of on-demand keywords for support beyond the scheduled text messages, and the program includes both structured and open-ended questions. The unique thing about This Is Quitting is that many of the messages were written by other young people, like this one from a user named Marge, to let users know that even if they feel like they're the only one in their peer group who's quitting, they're not alone. We launched the program January 18th of 2019, and since that time, more than 166,000 teens and young adults have enrolled. What we see is that users are actively engaged in the program. 70% set a quit date, the majority set it for the day they enroll. About half use those interactive keywords to get more out of the program, and 68% complete the full program. In terms of outcomes, 3 months after enrolling in the program, 19% of users say they haven't vaped in the past 30 days, which we know is a strong signal of successful abstinence among young people. We know that for people of all ages, quitting tobacco is a long-term process that may require multiple quit attempts. What these data show is the broad reach of this program and that it has helped thousands of young people looking for help quitting vaping. To help even more young people quit, we need more scientific evidence and practical knowledge around questions like how to define quitting, how to measure abstinence for e-cigarettes. There are also many important questions about whether nicotine replacement works for quitting e-cigarettes, what the appropriate dosing regimen should be. We know that many young people also vape marijuana or THC, and so it's critical to understand the best approaches to address co-use of marijuana and nicotine. The recent EVALI outbreak, the current COVID pandemic, have heightened awareness of the risks of various forms of tobacco use. As Dr. King noted previously, smoking is a risk factor for severe outcomes for COVID. The data about vaping and COVID are still emerging, but the bottom line is that it's always healthier not to inhale any chemicals of any kind into the lungs. And so the hope is that this heightened awareness will motivate young people to quit smoking and vaping and to look for available cessation resources to improve their chances of success. Thank you for your attention, and for more information about the work that we do at Truth Initiative, including our other tobacco cessation programs, please visit truthinitiative.org.
So thank you so much for everyone joining us so far. As you can be able to see here very shortly, all our speakers are here with us as promised. And this is time for our live Q&A. I want to remind our viewers who are watching us online, thank you for being here. And also, if you have questions, send them to grandrounds@cdc.gov. We have several questions already coming into the box. And so one question from Marquet. Does anyone have the data on smoking in the United States that's categorized by occupational groups?
Yeah, so this is Brian. We do have this data from the National Health Interview Survey, and it's been released by CDC and several MMWRs over the past several years. And basically what we've seen is there is some variability all by occupation and also different types of broader employment groups. And typically we see higher prevalence of smoking among more blue collar occupations and also certain occupations such as the hospitality industry and the restaurant sector. And so there's certainly marked disparities, but the good news is that we know what works to address these types of disparities as well in terms of implementing population-based interventions. And so an ideal way to accomplish that is smoke-free policies, which this report found helps not only protect people from secondhand smoke exposure, but also to actually promote cessation among current smokers.
Our next question comes from Conrad, who's commenting that the higher tobacco prices can be a major deterrent. For example, in New York City, they have a $4.35 per pack state excise tax and a city tax of $1.60. So in Australia, it's $25 per pack. Is there anything that we can do now to have some sort of universal national tax on cigarettes?
So I'll start and then I'll triage it over to Jillian, who worked on this project. I think it's important to note that there actually is a federal tax on cigarettes. It's a little bit over $1. In addition, there's also several state level taxes but there's large variability. The lowest is in Missouri, which is about 17 cents, and it's all the way up to well over $4 in New York State. So it's no surprise that the places with the higher taxes actually have the lower rates of smoking. And we know that increasing the price of tobacco products is the single most effective intervention for reducing consumption. But it's important to note that it's also part of a comprehensive approach. So Jillian, I don't know if you want to add on that based on the current findings in the current report.
Yeah, I would just add that in particular, this report found that when big policies like that are implemented, if they're implemented alongside tobacco cessation treatments, that can be the most effective approach for helping people to quit. So in other words, if there's a tax, if the tax has some of the funding going towards treatment, towards promotion of treatment, coverage of treatment, and just messages about the importance of quitting, that tax is much more likely to be effective. So that would be one of the best practices if you are a policymaker or a clinician that you could advocate for would be access to treatment and promotion of that treatment. We also found that it's not just allowing access, it's actually promoting it and letting people know that it's there.
I want to also remind our viewers that all of our slides, including the recorded version of the session itself, will be posted to Grand Rounds website, cdc.gov/grand-rounds. It gives us a few days to get that ready for posting, but they will be, and so the slides are available, and as is the entire presentation. Kendall wants to know, do you have any lessons about all of this for middle schoolers?
Amanda, do you want to touch on that, given a lot of the youth-focused work that Truth does?
Amanda, you're on mute on your end.
Am on mute. Sorry about that. Yes, great question. I think the first thing to note is that middle schoolers, high schoolers, what we're seeing is that young people are interested in quitting vaping. The numbers that were presented in my presentation dated back to May. We're now well over 176,000 young people that have enrolled in This Is Quitting. And what it tells us is that there's great demand. For parents and for teachers and administrators, I think that the key thing to know is that you're not going to discipline children, high school students out of e-cigarette use. Much like what Jillian just said, the important thing is to make supportive resources available, to have helpful conversations, to talk about e-cigarette use, what's driving their e-cigarette use, but then most importantly, to point them to resources available, to walk them through how to get through the school day without vaping, how to refuse the offer of an e-cigarette from someone in their peer group.
This is interesting. Angie brings up that we need to work more with the entertainment industry, more to reduce smoking in films. And for years, they cooperated, but now it seems like that needs some reinforcement. Are we doing anything to work with the entertainment industry?
So there has been a lot of momentum within the past several years, particularly around the ratings for certain types of movies. The 2012 Surgeon General's report actually concluded that smoking in the movies leads to increased smoking among young people. And so we certainly know that that's one of the many drivers that help promote the use of tobacco products among youth. And it's equally as important to consider the diversity of different tobacco products that youth are using, right? You know, e-cigarettes have been the most commonly used tobacco product among youth since 2014. And although we've done a really coordinated job of ensuring that youth are educated about the risks of smoking and the harms of regular cigarettes, there's still a knowledge gap when it comes to some of these emerging products. And so it's not just smoking in the movies, it's any form of tobacco product. And these types of visual themes and the active promotion of these products can certainly help promote youth use. So to that end, there have been some efforts in the past several years to help remove smoking as well as other forms of tobacco product use from pictures, both in movies and also on television. But there's certainly more that we can do in terms of educating the public and on this issue, not only the risks of these tobacco products, but removing them from the types of places where youth are going to see them, and it could potentially promote initiation among this population.
Yours has a more clinically focused question. What parts of the body can be damaged because of smoking, and for how long can someone smoke before they start experiencing problems? So a little different take.
Yeah, Rachel, did you want to touch on some of this given the health effects that were broached in Chapter 4 of the report that you covered?
Rachel, there you go.
Hi, yeah. Smoking really damages several organ systems in the body. Very well known, of course, is the lung, respiratory system, cardiovascular system. And these effects and harms can happen even at low levels of smoking. So it's really important to quit completely to reduce your risk from tobacco-related diseases.
And if I can jump in, I think the second part of the question was about how long can you smoke without harms? I would frame it around quitting. And so we know that the earlier that you quit, the more likely your life expectancy is to be close to a non-smoker. But there is a benefit to life expectancy from quitting at any age. So no matter how old you are, no matter how long you've smoked, it is very important to make a quit attempt, to continue to try to quit, to get assistance if that would be helpful to you, to get social support. Quitting at any age has a benefit. And that's another big conclusion of this and past Surgeon General's reports.
Yes, thanks so much, Jillian.
What is CDC and other agencies that are on this call? What are we doing to address the dramatic disparities amongst American Indians in smoking prevalence? And how dramatic is that disparity from the current low of the 14% prevalence for others?
So I'll start and then turn it over to others as well. There's certainly a marked disparity among multiple populations, and there's been a longstanding disparity among American Indians and Alaska Natives for many years. You have prevalence rates in the high 20% or higher among this population compared to low teens among the general population. And so this is certainly a key population where it's critical that we ensure that we have the evidence-based resources that we know work. And to that end, one of the most important aspects of this is what gets measured gets done. And so in order to know that disparities exist, it's important that we continue to monitor it. And so this report acknowledged some of those disparities through our surveillance, but importantly, once we acknowledge those disparities, it's also essential that we implement policies to ensure at the population level that it makes these products less acceptable, less accessible to be used, and also ensuring that those clinical interventions. And a key component of this is the sacred use of tobacco. And we know that there's long-standing a context for tobacco to be used in a sacred context among this population. And so when we're talking about issues to address tobacco use, it's commercial tobacco use among this population, which is very distinct from sacred tobacco use. And so when we're talking about commercial tobacco, the same evidence-based interventions that we know work for other populations are also going to work among this population. And to that end, there's been commendable progress among several tribes across the country implementing those types of proven strategies like smoke-free policies to help not only reduce secondhand smoke exposure, but also to promote cessation. And then on the other end, there's also the importance of ensuring that we have access to some of these clinical and health systems approaches that were described in this report. So I'm not sure if others, either Jillian or Rachel, if you want to touch on some of that in terms of ensuring that the access to those evidence-based resources like quit lines and healthcare systems.
Yeah, so and I would point to a couple different communities, tribal nations in Oklahoma and in Minnesota in particular, that have really worked together as communities to come up with the best fit for their community, as well as the best way to message around keeping tobacco sacred and leveraging treatment resources. Indian Health Services is another organization that can provide some clinical support and be helpful. But I think the takeaways from the communities that I've been able to speak with is that really involving the community, involving tribal leaders, involving tribal members in the process of how you think about treatment resources, what is best for your community and how to message those can be very successful.
Okay, I think these questions are coming from our Facebook Live audience. Are there plans to expand the quitline prescription offerings to include short-term and long-term cessation support to increase effectiveness of quitting, as indicated in Jillian's report?
I can step in and take that. So quit lines are mostly funded through states. And so the states work with the community to figure out what they can provide. And there's a bit of a patchwork of what sort of medications are covered from quit line to quit line, depending on the state. And I know from having worked with many states that they do their best to maximize what's available. And I think reports like this Surgeon General's report can be helpful in advocating for certain types of coverage. So one of the things that this report found in particular was that combining different types of nicotine replacement medications was more effective in terms of promoting cessation than using one form alone. So those are the types of things that can help drive policy in the field, as well as funding. One of the other things that this report found was that comprehensive tobacco control programs lead to higher rates of tobacco cessation, especially when those programs are well funded. And so we are in a climate where funding, particularly for public health, is hard to come by. And so that's certainly something that will play into the medications that are available. The last thing I would say is work with your clinician, because it may be that even if your state tobacco quit line is not able to cover a medicine, your health insurance is, and your clinician can help connect you, even if those are forms of medication that are not traditionally available through prescription. There are sometimes ways to have those be covered. So hopefully that's helpful.
Here's a suggestion, and it would be good for anyone to comment on. And why is it that all public health print communication does not have a one-liner on tobacco cessation support, since smoking is the leading cause of preventable disease, disability, and death in the United States? So what they're suggesting is just a one-liner on all print materials that we publish, not just CDC, but any public health entity.
I think it's a point that's duly noted, and we'd certainly agree with. We know that smoking is the leading cause of preventable disease and death in this country. And as we heard before, 480,000 deaths per year. And for each death, there's 30 people that are living with a smoking-related disease, so 16 million Americans. And so given that we've got 34 million Americans that are still smoking, there's certainly a key audience that we still continue to need to reach. So it's certainly important to acknowledge. And the other aspect here to consider is, as Dr. Grana was noted, there's so many health outcomes associated with smoking. It harms nearly every organ of the body. And so smoking as a risk factor is really intertwined in a lot of other public health work, whether you're talking about coronary health outcomes, cancer, including things that you don't necessarily think about, like rheumatoid arthritis or macular degeneration. There's a lot of health outcomes. And given that smoking is a risk factor, it just reinforces the point that I strongly agree with, that we continue to educate the public about those risks, but also importantly, what they can do to reduce those risks. And that's really where this report comes in, giving us that evidence base to ensure that we have that type of messaging that's evidence-based, science-based, to help reinforce that type of language on those types of deliverables like you've noted.
I'm going to, we're down to our last couple of minutes. I'm going to try to edit this question, but also a statement. Here in Georgia, a coalition of more than 36 groups sent to Governor Brian Kemp and lawmakers a letter asking them to support a tobacco tax hike, tripling the current tax and other measures to mitigate spending cuts, thus balancing the Georgia budget on the backs of the most vulnerable populations. They are the current smokers. What impact might this have on populations experiencing disparities who don't have access to insurance service to support quits and quit attempts?
So I'm happy to start, and then I'll also turn it over to Jillian or Rachel to touch on some of the issues in terms of reach of interventions. I think it's important to note that increasing price is the single most effective intervention to reduce consumption. And the available science documents that it can be particularly effective among certain populations, and that includes low socioeconomic populations as well as young people. But it's also part of a comprehensive approach. And so increasing price is not the only lever to push to ensure that we reduce smoking rates. It includes things like smoke-free policies, mass media campaigns, as well as state and community interventions, novel strategies that we're starting to see, increasing the age of sale to tobacco 21. So it's not one and only tool in our toolkit, but it's one of many. And we know that there's also multiple ways that you can increase tobacco product price. Excise tax is one of them, but there's minimum price laws on reducing buy downs or coupons that can be used on these products. So there's a lot of levers that can be utilized, but it's important to note that we know that this is a highly effective intervention, and it can be particularly effective among certain populations, including those with lower socioeconomic status who are spending a sizable portion of their income on cigarettes. That being said, it's also important to note that when these interventions come out, it's an ideal opportunity to leverage to promote those evidence-based resources that we know work, including quit lines and other interventions. And so I'll turn it over to colleagues to really touch on that in terms of ensuring that we're reaching all populations, particularly those who are most vulnerable, with those interventions that were outlined in this report that we know work.
I wish we had time to hear everyone's response to that question. Unfortunately, we are at the end of our time today. I'm going to ask Dr. Iskander to close us out and remind everyone to please join us next month. Thank you. John?
Thank you very much, Susan. And I'll close with 3 brief comments. First of all, I'd like us all to give a virtual standing ovation to our outstanding presenters and to the Surgeon General of the United States. Thank you all very much. Second of all, I have a personal message to my brother-in-law, Bill. It is long past time for you to quit. And third, please join us next month for Public Health Grand Rounds. Thank you.